As you can imagine, I will not be telling you about best options, but I will just propose some considerations that must be taken into consideration. So Africa is so heterogeneous with distinct regions which have specificities, both economically and geographically. So you would have the north of Africa and part of South Africa, which are not low middle income and therefore have different challenges. While most of the middle Africa, as it is called, East, West, Central Africa is in red. But there's some progress being made. Some trends in financial indicators are encouraging. Total health expenditure is increasing. External resources on health spending are stable, and general government health expenditure, on the other hand, remains below 5% of the GDP. We are not doing so badly. The prevalence of HIV is reducing, new cases are down, and many more people have access to antiretroviral therapies. However, against this backdrop of a reduction in communicable diseases, we are faced with an increasing burden of non-communicable diseases. So we all know that worldwide, so many people lack access to renal replacement therapy. And over 90% of these are in low and lower middle income countries. And as we would expect, only about 9% of Africans who require dialysis are getting it. And this is not surprising, because in low income countries and low middle income countries, there is a direct association between prevalence of patients on hemodialysis and GDP. So as GDP increases in this category of countries, the prevalence increases, which is not the same in high income countries, where GDP has no impact on the prevalence. You've seen this slide. Accessibility to dialysis is so limited in Africa. We can see that so many people don't have access, so many countries, people don't have access to dialysis renal replacement therapy when they need it. And most of these patients, the patients who have access, are mainly put on hemodialysis. There is underutilization of PD. You've seen this slide. Everybody knows that so many people, most of the people who start dialysis in Africa, especially sub-Saharan Africa, would withdraw within 3 months, and after a year, you have less than a third who are still on treatment. So we all know that what is happening now is not sustainable. There is a growth of dialysis units all over, most of them in private, but they all fold up with time, or the patients stop with time. So what are the barriers to sustainable dialysis care? We don't have good quality data to even know the burden of the disease. And if you don't know the burden, how do you plan? There is poor funding. We all know dialysis is not considered a priority, so not funded by most governments. There is inadequate infrastructure for dialysis, whether it's peritoneal or hemodialysis. There's shortage of trained personnel, lack of regulatory frameworks for quality assurance, and of course, there's poor governance. Most African countries don't have registries, sub-Saharan Africa. And even when we say we have registries, they are mainly dialysis registries. So the burden of disease is not known. We don't even know the number of people who don't have access to treatment because they are not recorded. Funding is the single most important barrier. So many competing health priorities. And because we don't know the numbers of those who need renal replacement therapy, it's difficult to prioritize. This has led to different policies like rationing, where somebody decides who goes on treatment and who doesn't. There is high out-of-pocket expenditure, leaving so many patients to decide, to choose between leaving and and educating their children. Because of the lack of funding and high out-of-pocket expenditure, the few who go on to the treatment are non-adherent. Because of that, the treatment they get is of poor quality. So we have high withdrawal rates, deaths, and of course, all this is also linked to the high cost of supplies. In terms of funding models, there are so many that exist in Africa. Very few countries like Kenya are lucky to have a publicly funded system, but in many other countries where government gives partially funds, the high out-of-pocket costs are so exorbitant, which leads to catastrophic expenditure, as we've heard earlier. When we look at the proportion of treatment costs paid directly by patients, if we look at Africa, you'd see that sometimes it goes right to 100%. In terms of infrastructure and logistics, the few centers that exist are so overcrowded because the number of dialysis machines, for example, which exist, don't match the demand. And most of the centers have all refurbished machines with no technicians or technologists. Centers are mainly situated in urban areas. And dialysis, especially hemodialysis, depends on other social amenities like electricity and water, which are not readily available all over. And when we look at peritoneal dialysis, it also requires good housing condition and a support system, making it very difficult. Personnel, the few who are trained are all moving abroad for greener pastures. And those who stay behind don't want to continue because of moral distress, because of the conditions of their patients, because of the lack of the necessary requirements. In a recent survey we conducted amongst African nephrologists, 46% of those we interviewed regretted having chosen the profession because of the challenges they face. Whether nephrologists, technicians, nurses, counselors, psychologists, or dietitians, there is a shortage. Governance issues. We don't have regulatory frameworks for quality assurance. We are witnessing a growth of private dialysis units, especially for profit. Nobody regulates the quality of care, which goes in there, because there's no standardization of dialysis care in most countries. Poor management, even in countries like mine, where government subsidizes dialysis, poor management and governance issues lead to frequent stockouts. In a year, in my country, we have about 6 stockouts. Corruption. I looked at this paper by the Saving Young Lives team in Tanzania, which noted that customs and fees collected along the roads from the port when they collect the consumables accounted for an additional 25% rise in the cost of supplies. We all know recently about a corruption scandal involving one of the dialysis industries, And in that scandal, 7 West African countries are involved in exaggeration of prices. So all this are stopping us from getting to sustainability. Then health personnel barriers. Everybody wants to have a private hemodialysis unit because the reimbursement is more interesting than PD. And maybe there's industry influence. So, what are the things we can do to work towards sustainability in dialysis care? We need data, and thank you, EDTA, for supporting us. We need good data. We need to know the burden of disease in Africa. We need to know the outcomes based on different dialysis methods, because people are always saying, when they talk, they say, oh, transplantation is cheaper, PD is cheaper than hemodialysis, but we need data from Africa. We need to know the real situation. We need registries, good registries, and thank you, Ravin, for the efforts you are making to get registries in Africa. Vivek just showed this slide. We cannot have sustainable dialysis care without an integrated care approach. We must prevent kidney disease. We must reduce the number of people requiring dialysis. We must also think of taking them off dialysis that's developing transplantation. We must treat chronic kidney disease. Not all patients would benefit from dialysis, as Vivek said. So we need to develop a guidance document on the choice of ESKD care. Let us not be driven by profit to put everybody on dialysis. Some people would do better on conservative care. Rationing, which has been used in some settings, is an ethical dilemma that I wouldn't want to talk about. So, what choice of dialysis would you do? It all depends on the context. It all depends on your available manpower. Peritoneal dialysis is cheaper than hemodialysis only when you have local manufacturing of PD supplies. In other countries like Thailand and Hong Kong, there is a model of PD First program where patients are encouraged, are enticed to choose PD over hemodialysis. And this is cheaper because of the local availability of supplies. So you can't just say, because, oh, it is cheaper, I would start. There are certain things you must do. Dialyzer reuse. I know some countries in Africa are still doing that, but when you do the real cost evaluation, taking into consideration the advantages and disadvantages, I don't know where the balance weighs. I read a review recently, and it seems that we need more data to conclude. We can, however, minimize the cost of dialysis by a detailed economic evaluation. We should do a price component of dialysis supplies, because this would help us to know which parts of the supply chain are very expensive and see ways to reduce that. In a recent analysis of the insulin price components, for example, which took into consideration the manufacturer's price, the banking, port clearance, overhead costs, retail, wholesale, dispense costs, it was very interesting to note that the cost of insulin to Ghana and Uganda, the 2 African countries which were studied, increased by almost 500% due to markups, overhead costs at the retail and wholesale. Not even the taxes, because government exempted all this from taxes. So we must know why the cost of supplies is going up so that we can actually address those different issues. Transportation of supplies. In the Saving Young Lives program in Africa, Tanzania, to be specific, 25% of the cost of PD was due to transportation, meaning that by local manufacturing of fluids and supplies, we can bring down the cost and we would create jobs. We can also think of group purchasing by countries, by regions. We can imagine that in a country with so many dialysis centers, they can come together and purchase. We can have regions coming together, maybe having an industry to produce, and that would be cost effective. Many governments are ready and are already giving tax exemptions, which is also help. Funding. We are all advocating for the inclusion of dialysis care in the universal health coverage. However, whether it is universal health coverage or whatever means, you need money. And if I may quote Ban Ki-moon last week, said the only way to reach equitable universal health coverage is through a publicly financed single-payer system. We can't achieve universal health coverage with donations. We can't depend on others. We have to look for a way. Where can this money come from? Can be from taxes. In my country, a percentage of income for every citizen is taken as television tax. Yeah, for television tax. Whether you watch television or not, you have to. So I remember, I think in another country, if I'm not mistaken, the Ivory Coast, for a telephone company decided to give a percentage of every call of the money or something like that towards dialysis. So there are many things we can do. We can get community participation to join in, maybe in volunteering for the other aspects of dialysis care and NGOs. As I said before, donations are not sustainable. We can't develop a sustainable system with donations. Public-private partnership, which is the thing now. Everybody is talking about it, with some success stories in Asia. But again, these private partners are mainly industries. No, industry does not work for free. Industry works for profit. So if you don't have money to pay for the partnership, it will not work. So many countries are folding up. I listened to the president of the Bahamas in the US saying the other day, the costs that they have to pay, despite the partnership, the quality of care has improved, but he doesn't think they are able to continue in the partnership because they are getting suffocated. So don't be fooled. Industry doesn't go where there's no profit. And in a recent paper from Lesotho, we actually found out that it could be more expensive, even in the long run, when you are in public-private partnership. So you must, as you go into it, you must study, get somebody who understands the figures to study and review the agreement diligently. Training. The shortage of doctors. I must say that so much is happening in terms of training. We have regional training centers in Africa, and thanks to ISN, so many nephrologists have been trained, and of course IPNA. The problem is keeping them. You can't stop somebody to look for greener pastures. So we, again, must work with our governments to improve the conditions, and I'm sure if dialysis becomes sustainable, they would stay. We can also think of task sharing and shifting. For example, peritoneal dialysis catheters can be placed by nurses and GPs. We can develop regional cooperation, sharing expertise, and of course, occasions like this with hands-on workshops are there to improve our skills. Okay. In terms of quality assurance, we need to regulate, control the practice and infrastructure of dialysis. We need standardization of care. So I think AFRAN and AFNA should be able to put down something which people can use to control what is being done, especially in the private centers. What of certifications of centers? And of course, people must be held accountable for whatever they are doing. So in conclusion, I would say, I can't tell you of a best option, but I can tell you, I just shared with you certain things that you must consider in deciding what your best option is. Dialysis care in Africa is daunting. There's a growth of dialysis facilities. They need to work with governments we need to work with governments to make dialysis care sustainable. We must help them. We must discuss with them. We must propose to them what can be done. We must advocate for dialysis care to be included in the UHC package. We need data. We need an integrated ESKD care model which encompasses prevention, conservative supportive care, and renal replacement therapy. And this care should be provided by qualified kidney care professionals if we want to strive for sustainability. We have the opportunity to team up together for South-South cooperation if you want. We should have dialysis supplies produced in the continent if we want to reduce costs and have sustainable dialysis care. Asante sana. Merci beaucoup. Thank you.